Dr. Brent, the lecturer on living with COVID-19 in dental practice in the UK. And Dr. Weller will share with you how dentists and dental clinics in UK went through the pandemic since the COVID-19 outbreak in March 2020. From the cessation of operation to see emergency patients only, and from offering more comprehensive treatments to resumption of normal provision of patient care with vaccination and full PPE. Regarding Dr. Brent, he spent a year working from the NHS in London before spending 16 years in the Royal Air Force, where he experienced life as a dental officer in the UK, Germany, Italy, as well as in the British Embassy in Moscow. During that time, he gained his MSc in prosthodontics from the Eastman Dental Hospital and began teaching in the MGDS program and carrying out practice inspections. In the past, Dr. Weller has been an examiner for the MGDS at the Royal College of Surgeons of England and Edinburgh, visiting hundreds of surgeries to examine the quality of dental care provided and to assess the regulatory compliance in the UK, Hong Kong, and also in the Bahrain. Until recent, Dr. Weller was an external examiner of the MDD examination in Hong Kong. And he was, until 2020, a member of the General Dental Council, UK, Fitness to Practice Panel, and was a chairman of the GDC, Fitness to Practice hearings. He has also lectured on quality assurance, practice inspections, and audits in Hong Kong. Dr. Weller married with his lovely wife, Debbie, and live in Norfolk, England. They have 5 children, and all now adult, and they all got 5 grandchildren. Over the years, Dr. Weller carried out multiple practice visits at home and abroad to assess the service provided, the quality delivery, the practice facilities and equipment, the QA, and audits procedures and standards compliance in general. As a member of the GDC's Fitness to Practice panel, he has gained further valuable experience for standards of care and also delivery of services. Dr. Weller tried to retire in 2021 from his work with the RAF, but the shortages of staff caused by COVID-19 required him to return to work and cover clinical treatment needs. He now continues to provide forensic services to the folks, owners, service, and practice inspection. Dr. Weller is also the advisor of our clinic self-inspection program. He was given valuable advice to us to conduct the program successfully. And may I now invite Dr. Weller to deliver his lecture. Members who have questions may feel free to put forward their questions at the end of this session, the Q&A, immediately after the presentation. So may I pass the time to Dr. Weller, please.
Good evening in Hong Kong. My name is Brent Weller. I'm a general dental practitioner. I've been a specialist in prosthodontics in the past with about 40 years of clinical experience, although I'm about to retire in the next couple of years because I'm getting older. First of all, let me apologise for doing this as a recording, which is something I've not done before. I'm much more used to live sessions, but as we speak today, I'm on holiday in the cold, wet and windy far north of Scotland, where we decided it may be hard to rely upon the quality and strength of internet connections. For several years now, I've assisted with examinations in Hong Kong, and more recently with your excellent and, in my opinion, world-beating clinical self-inspection program. And I've been asked to talk to you today about my experience of dental practice in the UK during and continuing within the COVID-19 pandemic. My normal daily work has been treating both civilian and military personnel on this Royal Air Force base. within the Defence Dental Services. And as you can see, there's a lot of us, and we work in very close proximity to one another, which of course with a potential COVID problem has issues in terms of crowding. Please forgive the typo on here. Early in 2020, not 2022 as I've written there, early in 2020, we realized that a major storm was developing in China and spreading rapidly across the world. And this was the approaching COVID-19 pandemic. At the time of the beginning of the outbreak, I was actually working in London for the General Dental Council's Fitness to Practice Committee, chairing a hearing for some poor dentist who'd got themselves into trouble, and we were trying to resolve all of his issues. And halfway through the hearing, at very short notice, we were all sent home from London and told to stay indoors, go home, stay indoors, do not go to work. And of course, our immediate concern is what is going to happen to our practices and, most importantly, to the needs of our patients, especially those with emergency issues. However, the spreading pandemic was becoming a major issue and was working its way rapidly across the world, as you can see from this map. We had the first death from coronavirus in the UK around the 5th of March, early in March, and it was becoming clear that this problem was one that was going to hit us very hard. Our newspapers were full of serious concerns about how many people would die and how we could possibly cope with and survive during such a crisis. So we were literally locked down for 3 weeks. This was 2 weeks after the initial warnings, and Britain was in lockdown. There was no travel unless it was essential. We couldn't go and see friends and family. We could only exercise once a day outside, and there were significant fines of up to £1,000 if we broke the rules. Normally, parts of London, which are suitably crowded, as you can see from this picture of Piccadilly Circus on the right-hand side of your screen, Piccadilly before, busy place, lots of people in close contact. Piccadilly after the lockdown or during the lockdown, completely deserted. And rather eerie sights in the middle of central London, here towards the Houses of Parliament, completely empty. And Oxford Street, which you probably know from your visits in the past, a very busy place, was completely deserted. And this is frankly unheard of. And in the space of a few weeks, my area, I live and work here in North Norfolk, and we were receiving up to 311 cases a day. And this got worse. This is a zoom in on that area. And I live in this area here, which is dark red. And we were beginning to approach the state of more than 5,000 coronavirus cases per million. And of course, at this stage, nobody was vaccinated, and the elderly and physically vulnerable were at great risk. And this left us with an obvious clinical problem. We had empty surgeries, very clean, but empty, and we couldn't see any patients. And again, this gave rise to the obvious issue that there were still patients with emergencies, and we did not know how we could treat them. Our normal clinic would be much like this. We'd be open in a normal way with standard PPE, standard personal protective equipment. So simply fluid-resistant surgical masks, normal masks, eye protection, and not much else. But now we had the unsolved dilemma of how to protect ourselves, our team, and our patients from what was appearing to be a potentially deadly respiratory disease. Some interesting ideas were mooted. Amongst them, this one for using a betadine gargle and mouthwash, which is supposed to protect our oral and throat mucosa from viral infection, and also to use vitamin D to increase our resistance to the virus, none of which was scientifically proven and may or may not have worked in protecting us in the early days when the science was as yet unestablished. We started to receive guidance that in public places, we should start to wear face masks. The general public, and in fact the government initially were quite sceptical about this, and it took quite a while for people to take on the obvious step that you often do in Hong Kong, which is to wear a mask, not so much to protect yourself, but to protect those around you if you had signs and symptoms of any form of respiratory disease. So this took a while to happen. When it did, we took hold of it very effectively. But as clinicians, we began to be told that the best sort of masks were FFP2 and FFP3 masks, and these were agreed for clinical use and came with very detailed instructions on how to use such face masks or respirators. And we ended up using FFP3s mostly. And as I'm sure you're aware, these masks are not easy to fit, but once fitted can be very effective. They're difficult to work with if you've got beards and other forms of facial hair, but they can be adapted to give good protection. However, initially for us, supply was a major issue. Our government was not fully prepared, and certainly we didn't have very many of these in clinics, and we were hunting around trying to buy them all sorts of places. And just here, as you can see from this slide, a box of 40 FFP2s initially were on sale to us for £239 plus tax. So that would have worked out at around £7 or 70 Hong Kong dollars per mask. And the big question for us obviously was, this is a dangerous virus, the science is unknown, and it's going to be expensive to protect everybody. Who's going to pay for it? Is it going to be paid for by us in the clinics to our obvious financial detriment? Is it going to be paid for by the patients by increasing their fees? Is it going to be paid for by the government? FFP3 masks were eventually supplied to us, but of course, the greater problem with this is that we're not all the same shape. Men and women often have very different size and shaped faces. Our teams were made up of obviously men and women. Not all faces are the same, not all shapes are the same, and getting something to fit that we knew was effectively fitting and providing good safe protection became a big issue. These are no use wearing if they're going to leak. Excuse me. So we had to buy in several types of masks initially to try and find enough adaptability that these could be made to fit all members of our team. And as you can see from this slide, and I'm sure you're aware yourselves, there are many different varieties of FFP2 and 3 masks. So we ended up with our stock cupboards completely full of various sorts. And we had a huge supply of 4 different types of masks. And you can imagine the cost of this, given the numbers that we were obliged to purchase and the fact that they have to be disposed of after single use. In order to test that these masks were fitting properly, we went through a complex fit testing process. And you can see that this young lady is wearing an interesting hood that was fitted over her head and mask, sealed around the edges in order to test the effectiveness of the fit. And here, a very smelly spray is being inserted into the hood with vapor testing of the mask to check the seal effectiveness. And this was done with us in various positions, walking around, talking, moving, going through all the movements that one would have to go through in a clinic, rather than just being completely stationary. Took a long time, probably an hour per person to be tested successfully to find at least one mask that worked. And in the end, we succeeded, but it took, as I say, quite a lot of time, a lot of trouble, and ultimately a lot of expense. Now, until this point, obviously patients had received very little treatment in any form of safety. Any treatments that we offered had to be non-aerosol generating. AGPs were forbidden. So only non-AGP treatments could be provided. So we couldn't use our air rotor fast handpieces. We couldn't use ultrasonics, and we couldn't carry out surgical type procedures, surgical extractions, for fear that they may generate some form of aerosol that could be loaded with viral particles. So the only real treatments we were able to offer initially were antibiotics and forms of pain release. Later on, we were able to use slow handpieces, place temporary fillings, and carry out simple extractions. But ultimately, patient contact was kept at an absolute minimum. Only when the full issues of PPE were properly resolved could we begin to return to providing AGP, aerosol generating types of treatments. The next problem we had was how to deal with protective clothing. There's no use working in our normal surgical clothing, as these would become infected very quickly. And most of the products that we were able to buy, luckily, were provided from China. And these became very rapidly available, thank goodness. Though it did seem to us slightly strange that the virus and all the protective clothing were both coming from China, but at least they came to our rescue and helped us out very quickly. Again, there were many different types and styles of protective PPE that were provided. Here's just some examples of the coveralls that we were provided with, different makes and different types of fitting. And these all took a lot of time to fit and to check. We needed PPE that in a surgery situation, for each patient that could be quickly put on and that could be quickly taken off afterwards, and it wasn't too difficult to negotiate. And if you imagine all of this was provided for routine conservation for patients, as we all know, there are many patients who are not particularly comfortable and they're a little bit scared when they come to the dentist. So to be confronted with us dressed like this, in addition to having to have some fairly routine dentistry provided, was a daunting prospect for most patients, but certainly for anybody who could possibly be a little bit nervous. We had a detailed advice on how to put the PPE on and how to take it off without further contamination risks. Obviously, once you've got a contaminated suit, you've got to get it off. You've got to get off a contaminated mask and not further contaminate yourself in the process. So we had very detailed instructions and what we call a donning and a doffing. Donning, putting on, doffing, taking off areas. Then the next issue, of course, is how to protect your facial tissues. The mucosa around the eye was a potential source of infection. So should we, what sort of facial protection should we choose? Should we use, again, always disposable? Should we use visors, as in the left-hand picture? Should we use goggles? The problem, particularly with the visors, as seen on the left-hand side here, is that visibility could sometimes be difficult with all these layers. It would be quite easy to steam up. And once you're dressed and ready to operate, you really can't touch your loops to make any minor adjustments without having to change gloves and everything else. So it became a complex and daunting procedure. However, in the end, it worked, and we got used to it, and we were like that probably for more than a year. So here we are. This is me, fully prepared and hermetically sealed to replace one MOD upper premolar restoration However, this was the precautions that we had to take in order to make sure that we were protected, the patients were protected, and as yet the science was unproven, so we simply had to assume the worst and make sure that everything was correctly done. Unfortunately, during that summer, it was very hot. It was very hot and very sweaty, and the treatments became long and very uncomfortable. It was quite possible, if you're doing something like a molar endodontics, that you could be with your patient for an hour and a half, and then inside this this suit, etc., for verging on 2 hours in very hot and sweaty and uncomfortable conditions. And we would often end up completely soaked underneath and have to go and change all our clothing, have a shower, and see the next patient. And that, of course, in itself becomes a problem. Every procedure takes twice as long, if not more than twice as long, to carry out. So you can only see half as many patients, and everything becomes twice as expensive as it was before. Excuse me. So after treatments were now being able to be provided involving aerosol generating procedures, i.e. routine conservation or crown preparation or molar endodontics, or even use of ultrasonic scalers, we often had to change completely. We had to remove our personal protective equipment safely. And then we had to leave the surgery fallow or empty for 30 to 40 minutes in order to allow the air to settle and for a complete further change of the air within the surgery. So you'd have to remove your PPE, leave the surgery, make sure you didn't contaminate anything, leaving all your PPE on the floor in the surgery, go outside, clean your hands, get changed, and then only after 30 or 40 minutes, depending on what the government guidance was at the time, then go back into the surgery wearing regular masks, wearing FFP3 masks, and decontaminate the surgery after the fallow period. So good hand care became even more important. I think as a profession, we dentists are probably ahead of all of the rest of the medical and surgical world in our hand care. The fact that we clean our hands before, after, and often during treatments would suggest that we have very, very good hand cleansing procedures. But this became even more essential than it was normally. The hand pumps of 70% alcohol began to appear everywhere. I mean, literally everywhere. The waiting room, the corridors, inside and outside of changing rooms, and obviously inside and outside of the surgeries. And there was strict advice for everybody, not just ourselves, but for the patients, to ensure that hand cleansing was an absolute priority. And these little hand cleansing stations, as I say, were everywhere. First of all, the alcohol rub for both ourselves and the patients, advice on how to use it, but also some form of moisturizing cream to help protect our otherwise rather vulnerable skin. And you don't want your skin cracking up in this situation. The next issue, of course, was ventilation of the surgery, both during and after clinical procedures, again, usually aerosol generating procedures. It was essential to change the air within the surgery, completely change it numerous times per hour. I forget the exact number, but I think we set a target of 6 times per hour, but I stand to be corrected on that. So we were using a combination of existing and apparently very effective fan type ventilations, extractor ventilation. We were opening the windows in the surgery during these procedures. That's okay in the summer. It's not so good in the middle of winter when it just got freezing cold. These are the extractor fans in surgery. Open windows, and of course, air conditioning units. So the combination left us with the ability, or at least the theoretical ability, to change the air within the surgery enough times per hour to further reduce the potential aerosol or viral load within the air, within the surgery. but not just hand procedures. Cross-infection control and all areas of health and safety had to be reconsidered and replanned in order to make sure that we had everything under complete review and complete control. So this meant that, of course, we had to have the highest possible standards of sterilisation and cross-infection control. So multiple use of autoclaves in a separate CSSD, everything being logged as per normal, the pre-operative checks of the equipment, and then everything bagged and protected correctly, as we would normally do, but taking even greater care to check that everything was done properly. So as a result of all of this, I apologise for this slightly busy slide, but it's important to go through it. The patient journey had become very complicated from their arrival in the surgery to their departure. We had to make sure that they were safe, that we were safe, and that the environment was left as uncontaminated as possible. So point one, before any appointments, the patients were given a telephone pre-appraisal before arriving in the clinic. They were given arrival instructions and told what they would be going through, what we would be wearing, and what to expect in terms of their journey through the building. So the clinic doors were kept locked. Patients waited outside until their appointment time and were not allowed in until exactly their appointment time. And then there was controlled entry. So patients would be met at the door by one of the team. Their temperature would be checked. Their medical history would be checked and updated. And of course, their possible contact with COVID infected patients would be reviewed. And if necessary, they'd be turned away if there had been recent contact. Patients were then given masks to put on if they didn't have good ones with them already. And they were taken to the hand cleansing stations in order to make sure that their hands were suitably clean. And where physically possible, we operated one-way systems through the clinic so that the patients never went back on their own steps. They came in through one door and left through another. And there was a strict one-way system through the building, into the waiting area, into the surgery, and out through a separate door. Ideally, only one patient at a time was allowed into the waiting area. If not possible, then safe spacing whilst they were waiting, but we found it far simpler to either have one patient at a time or to stagger our appointments so that I would receive my patient and the next patient's appointment for one of the other clinicians would be maybe 15 minutes later, so there was no chance of them crossing paths. They would then meet the clinical team. We would explain that we were still the nice, kind, caring, gentle people underneath, but we had to wear the PPE in order to carry out the procedure safely. The procedure was explained, and most patients who obviously knew their clinician well beforehand were happy to accept that this was the only way that we could carry out their treatment. Where possible, rubber dam was placed in order to further reduce the viral load from the patient's mucosa. High-speed suction was used, and the amount of time generating any aerosol was kept to an absolute minimum, so cavities were cut fairly quickly, or crown perhaps done quickly, in order to ensure that we reduced the amount of period of time generating aerosols, and also to reduce the size of that viral load. After treatment, the patient would then leave via the one-way system, and any further appointments were made by telephone rather than the patients going back through the practice to the reception area. The alternative was that they had to go back to the front door, wait for a suitable opportunity, go to reception, go through the whole palaver, and walk through the practice one-way system. So it's clearly easier for them to make further appointments by telephone. We then in the surgery would safely remove our PPE, leave it in the surgery, go outside, clean ourselves down, and leave the surgery fallow or empty for 30 or 40 minutes, and then only go back into clean down after that. So as you can see, this made the whole process so complicated, so expensive, and so incredibly time consuming. But at the time, it seemed the only way that we could safely protect everybody. After a year, the way ahead became possibly simpler and clearer. And as you can see, once the vaccines became available, we received our vaccines. I received my first vaccination on 22nd of January 2021, so almost a year after the start of the pandemic. And then I had my second vaccination in April, third one in October. So clearly a substantial part of the way ahead and a way of reducing the severity of this problem has been the use of vaccination, both for clinicians and obviously for patients, for all the public where possible. We've done an inordinate number of tests, usually lateral flow tests, self-testing and then self-isolating where necessary. We would undergo PCR tests, the government coordinated ones, which were more accurate. Very often, if one had a positive lateral flow test, you booked yourself in for a government PCR test. And then if that was positive, you were obliged to isolate until negatively testing. And of course, the big improvement, we all hope and pray, is that the virus has mutated. Initially, we thought the mutations would be a bigger problem, and they are in one way, but it's a blessing in another. Obviously, as you're aware, it would seem that the virus has become more contagious. So at the moment, or recently in the UK, maybe 1 in 20 people were testing positive, but very few people were actually ill. This was still a problem for those who are not vaccinated and for those with pre-existing medical conditions. But ultimately, for the vast majority of the population, it would appear that things are improving as a result of these changes. We've had to provide proof of vaccination wherever we go for many things, whether it's social or professional or wishing to travel. But this seems to have changed things dramatically for the good for us. So we now all, most of us have an app which shows us our National Health Service COVID pass and the date that pass expires, but that can be renewed in the absence of any positive testing. So we have a travel pass, which will allow us to do some international travel and to travel around the country. And we have a domestic pass, which again allows us to, for example, go into the theatre and to various other public venues. So at last, after 2 years in my case, we're able to leave the country and have a short holiday abroad, although that's clearly within the constraints of the countries that one is visiting. And sadly, I've still not yet been able to travel to Hong Kong, but hopefully that's coming soon when your laws and travel restrictions allow, and also obviously when your local problems with the virus have receded. So the current clinical situation in this country in April 2022. Now, because of the benefits of vaccination and the changes in the virus, the nature of the virus, we ask our patients to wear masks on arrival and departure into the clinic. There are regular lateral flow tests for clinicians, although the government has dropped or is dropping free lateral flow tests for the public, with the view that this should now be something that we should be able to live with rather than suffer under. And all treatments are now available in the surgery with no fallow, no quiet period to allow the surgery to recover. We still clean down the surgeries, obviously, very effectively between patients. As clinicians, we still wear FFP3 masks for any form of aerosol generating procedure, but only with disposable aprons and glasses or visors. We wear routine PPE as before for non-AGP AGP treatments. So simply the normal fluid-resistant surgical masks. And most of us are triple vaccinated, especially clinicians, and are either post-COVID or both. And so far, it appears that I still haven't caught it. I still haven't had a positive test. And I'm rather hoping that that situation continues. But with the current situation of high virulence, but poor or low levels of clinical symptoms, it's quite possible that I may have or have had it and simply not known. So the current situation, we now hope that the worst is over. The virus appears to be causing much less serious disease for most, and particularly for vaccinated people. The virus appears to be less serious, but is more contagious. More people may have it, but appear to be either symptomless or subclinical. So if this continues, we may choose to consider it as endemic, like the common cold or the common flu, or the flu viruses that go around every year. And these are not necessarily not serious. They can be very harmful. But we would consider it to be ultimately endemic, not harmless, but not worse, and rather than endemic, rather than the lethal pandemic that we have undergone and suffered from and lost so many valuable lives over the past 2 years. So we live in hope that the worst is past and that clinical life can return to something more normal, but with extra care. I hope that update and input helps you, and I will end this recording here, but I will be available, hopefully, if the internet works, later on to discuss and ask questions. Thank you.
Thank you, folks. If there are any questions, I'm happy to try and answer them, although I'm in a busy airport, so forgive me if the sound's not perfect.
Hello, Brent.
Hello, Brent.
Hello.
Hello, Brent.
Good to see you. Yeah.
How are you?
Hi.
Yeah. Yeah.
Very good, thank you. I'm in Aberdeen Airport at the moment.
Thank you very much for your informative lecture. And tonight we have Heston here and also our president, Dr. Nelson. We welcome any questions from the floor. And do we have any question now in the chat room? No, not yet. Maybe Heston can ask the first question.
Yeah. Ben, thank you very much for your presentation. I think that the Hong Kong colleagues is quite lucky that when the fifth wave struck Hong Kong, the virus is not as lethal as those in the early days of in England. Yeah, and then the Hong Kong colleagues is able that we're still quite intact. Yeah, and without much people get infected, and our patients seem to be safe. Yeah. One of the things you mentioned that in your presentation is that now you got your colleagues has got a routine RAT for them to make sure that they are COVID-free. But how about the patients? That do you recommend that a routine RAT for the patients when they come for the dental treatment? Yeah.
Yes, at the moment we're still we're wearing FFP3 masks currently for aerosol generating procedures, but we're just with an apron and eye protection. So better than pre-COVID, but not as bad as in the middle. Does that answer the question? So I couldn't hear it clearly.
Yeah, I mean that for the rapid antigen test, do you think that you will recommend that every patient come in your clinic to have the RAT first? Yeah.
We're not doing it, but I think it's a jolly good idea. The problem for us is that government has taken away free testing. So we are now expected as a community, we're not, as professions, not convinced that's a good idea. But the government has decided that we should all now just muck in and get on with it. And as a consequence, the masks are no longer compulsory in public places. Testing is going to be more difficult unless you're ill. My personal view would be that I would, certainly in your situation, I'd be asking patients to come at least with a lateral flow, an antigen test of some sort, just to show that negative on the day. If we get together with a crowd of friends amongst our particular social group and have dinner of a Friday evening, we will all test beforehand just to be on the safe side. But that's not government policy, but it's personal policy. So here I am in the airport with my mask. And actually here in Scotland, unlike England, because we have different local governments, here in Scotland, it's still compulsory to wear masks, whereas England has decided to, I think probably as a big experiment, to see how we cope without. So we'll see what happens. I'd be interested to see if that's what happens to you, where perhaps the Chinese government will say, let's slacken the rules in Hong Kong as a test, but not in the rest of China, to see how things go in a more sort of a smaller and more controlled environment. But it may be the way ahead. None of us knows the truth, do we, at this stage?
Yeah, I think that now in Hong Kong, because the government has issued that free RAT kits, that means free kits for all the citizens in here. Yeah, therefore, I think that the government is quite encouraging the people to do the RAT by themselves. And a lot of dental colleagues, use your recommendation is that to have RAT for each patient. And seem to be that our patients is quite accept that for this kind of practice. But of course, who is going to pay for it is another question that we will have to debate later. Yeah.
Also, before the COVID crisis, you in Hong Kong and in China and the Japanese as well were much better than us at simply putting on a mask if somebody got a cold, whereas it was unheard of here. So in a way, you were already a step ahead of us.
Thank you for your presentation. Yes, any from your experience, what do you think that the future of the dentistry will be changed by this pandemic? Yeah.
Very hard to tell, isn't it? I think the major problem is going to be the cost. It's going to become more expensive for patients. Either that, or we as clinicians will be spending more on equipment and PPE and having to foot the bills ourselves. So I think dentistry potentially could become much more expensive. And we will always be mindful every year, I think, of protection against all the various viral things that go around. We'll have to see. But yeah, I don't think, I think we'll just become more cautious and more protective of those around us. But I think as a profession, as I said in the presentation, I think as a profession, we have for a long time been a long way ahead of many of our other medical colleagues in terms of surgery cleanliness, of hand cleanliness, cross-infection management. And maybe we don't have to make too many changes, just to be a little stricter on the things that we're already doing.
Are there any questions from the chat room? No? Okay. Thank you very much, Brent.
No problem at all.
Yeah.
I look forward to seeing the next presentation.
Yeah.
Yeah. Sure.
Looking forward to see you physically.
Yeah, we are looking forward to see you physically.
Oh, please. Yeah. Let me know when it goes down to 7 days, and maybe I'll risk 7 days of isolation.
Yeah.
As long as you can organise, long as you can organise a comfortable isolation place for me, I'll be happy to come.
Yeah.
Okay. Best wishes to everybody. Yeah. All the best, and thank you for asking.
Nice.
Yeah. Look after yourselves. Take care. Stay safe.
Take care.